Hello and welcome to the Syria Clinical Education Post-COVID 2026 podcast on CELMoDs. I'm your host, Jervis Constanzo. Today's episode features Dr. Sagar Lonial from the Winship Cancer Institute of Emory University in Atlanta, Georgia, and Professor Mohamad Mohty from the Saint Antoine Hospital in Sorbonne University in Paris, France. They will be discussing next-generation CELMoDs, which include iberdomide and mezigdomide, for patients with multiple myeloma, including emerging data from clinical trials and combination strategies to optimize treatment plans. This episode is part of a larger educational program titled Redefining Myeloma Care, an expert roundtable on the potential of novel strategies across the disease spectrum. For more information on Drs. Lonial and Mohty, along with the link to the larger educational program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say about this topic.
Hello, I'm Dr. Sagar Lonial from the Winship Cancer Institute at Emory University in Atlanta. I'm joined by my colleague, Professor Mohamad Mohty from the Department of Saint Antoine Hospital and Sorbonne University in Paris, France. We were together at COMI and talked about a number of different important topics in the context of multiple myeloma. Welcome, Mohamad.
Thank you very much. It's a great pleasure to be with you today.
So I think one of the things we wanted to talk a little bit about today was some of the exciting data on CELMoDs. And I'll just get us started with a little bit differentiating CELMoDs from their previous cousins, the IMiDs, and then let you sort of tell us a little bit about your perceptions as well. So we know that the two CELMoDs that are furthest along in myeloma, which are mezigdomide and iberdomide, are structurally different and really, in my mind, have three nice differentiating points from lenalidomide or pomalidomide or even thalidomide. The first is much higher binding affinity, which allows you to actually induce cytotoxicity as opposed to cytostasis when you treat myeloma cells with them. The second is a better adverse event profile. And the third has to do with immune activation. And these, to me, represent three nice differences between the CELMoDs as well as their previous predecessors, Len and Pom. Tell me your thoughts about this and how you think it plays in clinical practice.
I think you nailed it very nicely, Sagar. We all know that the IMiDs, starting with the grandfather thalidomide, then lenalidomide, the father, the son, pomalidomide, represented a huge, I think, revolution in the field of multiple myeloma. I think they were transformative, whether in newly diagnosed multiple myeloma, but also in the relapse refractory setting. And I'm very excited about this new generation of IMiDs, the so-called CELMoDs, which represent an evolution beyond actually classical IMiDs, because as you summarized it nicely, they combine direct anti-tumor activity with profound immunomodulatory effects. They may restore sensitivity in heavily pretreated patients, and we owe this due to their mechanism of action. They are the next generation cereblon E3 ligase modulators. You insisted on the enhanced cereblon binding, and obviously this will lead to potent degradation of Ikaros, Aiolos, immune activation, and obviously overcoming resistance. And actually, from a mechanistic perspective, we're clearly here performing a sort of a cereblon pathway optimization with a stronger substrate degradation and immune activation. And this will lead, I believe, into synergy with some of the most active antibodies we use in myeloma.
Yeah, no, I think you've hit on a number of really important topics. And I think, from a clinical perspective, a question that I often get is, are they really more potent than Len and Pom? And while the best head-to-head comparison of Len and Iber is ongoing in the Excalibur maintenance trial, certainly the preliminary efficacy that Niels van de Donk has presented suggests that they are more likely to induce CRs and MRD negativity than what we'd seen with Len before. To me, the indirect comparison, particularly in newly diagnosed myeloma, when we look at the Iber-Dara-Dex combination as opposed to Maya, which was Len-Dara-Dex, the CR rate and MRD negativity rate is double in the Iber-Dara-Dex. Now, these are not exactly, they're not head-to-head randomized trials, but certainly that suggests that the potency you've hit upon that we've seen in preclinical data may actually bear out in clinical practice.
I fully agree with you. And actually, although we are missing or we will never have these so-called head-to-head comparisons, but we do have some strong indicators suggesting that the CELMoDs are probably, from a clinical standpoint, stronger and more potent than the classical IMiDs, because we've seen responses even in very difficult to treat populations. The activity seen in post-BCMA settings is very important. We've seen a strong activity in the triple-class refractory with durable responses. And the corollary for this, in my opinion, is that if we bring them into earlier lines and even into frontline, and you mentioned the Dara-Iberdomide-Dex combination, well, obviously, one would see even better responses. And you alluded in your introduction to the improved safety profile. And actually, improving the outcome of a given patient is about improving the efficacy, but also improving the safety, and the overall balance would be very positive. And this is why I'm very optimistic about the positioning of these new CELMoDs, not only in the advanced stage relapse refractory setting, where clearly we need them after failure of bispecific antibodies after CAR T cells, but also into earlier lines, especially in combination, for instance, maintenance after CAR T cells, or as a backbone for combinations in the sequencing strategies.
Yeah, no, really, really nice points. And I fully agree with you. I think a lot of what you are describing now, we've seen hints of in data we didn't have at COMI. And that is data from the Successor-2 trial that we've seen, at least preliminary data in the abstracts that were released from ASCO already. I think it's really, really exciting. Tell me your thoughts about what we know so far about the Successor-2 data. But that's a slightly different agent. It does have even more potency than iberdomide. And what I'm really intrigued by is the activity in high-risk myeloma, as well as the potential for activity in extramedullary disease that we've seen. Tell me your thoughts, because I know that that's a challenge for all of us dealing with those subsets of patients.
Exactly. These are the hard-to-treat patients, and based on the abstracts you're alluding to, and I'm very excited about to listen to the presentation during the next ASCO 2026 annual meeting. We do have a clear, potent signal about the efficacy in the hard-to-treat patient, namely the high-risk cytogenetics, but also, for instance, the extramedullary disease. And in my opinion, we owe this to the immune synergy that one can see between IMiDs and, for instance, proteasome inhibitors, but also probably the capacity of these agents to potentiate T-cell redirecting approaches. So at the end of the day, when you look to the full sequence of treatment, actually probably patients are going to do better.
Yeah, no, and whether it's Successor-2 or Successor-1 with mezigdomide, or Excalibur Relapse, which is Iber-Dara-Dex versus DVD, we know that trial hit its primary endpoint, and we're hopeful for an FDA approval. I think that these agents, in all the clinical situations you described, are going to be really important, not only for directly attacking myeloma, but potentially for resetting immune function, particularly in the context of repeated bouts of immune therapy. We know that T-cell exhaustion and other issues may limit the efficacy of many of our immune therapies. And these drugs, the CELMoDs, give us a way to perhaps rejuvenate the immune system in that context. Go ahead.
And I would like to add here, Sagar, something very important about the safety profile, because this is always a matter of concern. And we've seen, for instance, with the T-cell engagers, bispecific antibodies, that opportunistic infections are clearly a big concern. Here, we're talking mainly about hematologic toxicity and cytopenia, which is, I would say, the core business of hematologists, something that we relatively easily manage. The infectious risk is relatively mild, so we don't need the monitoring, the immunoglobulin systemic administration. So, and the tolerance in general is very good. And last but not least, I would add that the adoption by the community is going to be very quick, because experience accumulated from the historical IMiDs will help clinicians to adopt very quickly these new CELMoDs and navigate their toxicity management. So I'm quite optimistic about the advent of these CELMoDs, which will become central components of our anti-myeloma strategies.
Yeah, no, and I think, we've hit on a lot of the preclinical, the clinical data that we have available to us now from phase 2 trials, emerging phase 3 trials that we hope to have more granular data on. But what I want to shift our focus to in these last couple moments is really talking about sort of the future, the forward-thinking approaches. To me, and we've seen preliminary data combining T-cell engagers with iberdomide, combining T-cell engagers with mezigdomide. There are already data looking at T-cell engagers with len and pom in earlier lines of therapy. To me, a big question is a T-cell engager CELMoD combination as good or better than a CD38 CELMoD or a CD38 T-cell engager combination? I think this is the next big question that we need to answer in our field, right?
I fully agree. And actually, you're alluding to what I would personally call the next generation immunotherapy platforms. And we do have already some strong in vitro and animal data suggesting, for instance, that mezigdomide can allow for immune restoration. This is clearly needed when you are speaking about immunotherapy. So these CELMoDs will become central components of any future immune-based strategies, because they illustrate how modulation of the tumor microenvironment is becoming increasingly important. So I would say the field, thanks to CELMoDs and other innovations, is moving toward sort of a biology-driven combination than just rather sequential adding drugs one after each other.
Yeah. And we have spent a lot of time talking about T-cell engagers and the ability to potentiate efficacy by combining with CELMoDs. Let's get even a little closer to what's near and dear to your heart, which is cell therapy. Do you see a role for these in the context of CARs, whether they're in vivo or they're ex vivo, improving the quality of the pheresis product, improving the innate quality of the T cells before or after? Tell me what you see as the potential opportunities.
Absolutely. And I would say they can be useful at the different stages of any T-cell therapy. I think before apheresis or before administration of CAR T-cells, they can be helpful in terms of bridging, but also we know that they will have a positive impact on the T-cell fitness that we will use to manufacture the CAR T-cells. But also, I believe, although we like, all of us, the single-shot treatment with CAR T-cells, we need to acknowledge that we won't be able to cure every single patient with a single-shot CAR T-cell. And in many situations, especially the high-risk situations, but also the situations where your CAR T cell construct is maybe weaker because not all the CAR T constructs are equal. Definitely using these CELMoDs after CAR T cells to promote or to continue to trigger the immune reactivation and improve the efficacy of CAR T cells is going to be crucial.
Yeah, yeah. I mean, I think if you poll those of us who use a lot of cars, I think very few of us are doing no maintenance after a car. Whether it's switching targets or whether it's using an IMiD, hopefully in the future a CELMoD, at least for limited duration with the intent of trying to improve persistence. To me, that is a big difference between lymphoma CARs or ALL CARs versus myeloma CARs. The persistence is just so much longer in lymphoma and ALL, at least from my interpretation of the literature, and that may be a challenge when we're using a myeloma CAR.
Yeah, I can only agree with these statements because clearly with CELMoDs, we're not simply talking about stronger IMiDs. They are clearly the backbone of a new platform for immune modulation and reactivation in myeloma. And obviously, they will become, in my opinion, mandatory as partners with all the other different immune therapies, which are very promising and which we are using more and more routinely.
Yeah, no, fully agree, fully agree. And I think our field is moving so fast. There's already new data coming out at ASCO and at EHA, as well as at IMS and ASH. It's such an exciting time in a field that for so long had laid dormant. And it's every innovation is making a big difference for patients. Thank you again for your time, Professor Mohty, and again thank you for hosting us at your meeting. Absolutely delightful as always, and appreciate everybody listening to this really nice summary of, I think, the current, the present, and the future of CELMoD therapy in myeloma. Thank you.
Thank you very much, Professor Lonial, for the insightful discussion, and you're all very welcome to COMI 2027.
Thank you, Drs. Lonial and Mohty, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Redefining Myeloma Care, an expert roundtable on the potential of novel strategies across the disease spectrum, please click the link in the show notes. As always, thanks for listening.